Hi, I'm Tim Hall. I'm an acoustic physicist from the University of Wisconsin, Department of Medical Physics. And I'm going to talk today about breast elasticity imaging, talk a little bit about what we mean by elasticity, talk a little bit about what we've learned from more than 500 patient scans, and talk about where the technology is headed in the next few years. Okay, I'm Tim Hall. I'll be talking about breast elastography, some of our work. I want to point out that we have technical assistance from Siemens. They provide assistance that allows us to get into their system and do some of the programming that's necessary to execute the work that we're talking about here. Basic problem is breast cancer imaging, screening for breast cancer. And we know that there are a large fraction of women that are likely to get breast cancer. It's the second most common cancer among women. And we know also from the breast cancer screening trial, the Akron trial, that preliminary results suggest that ultrasound is really quite sensitive to detecting breast abnormalities, but it's not sufficiently specific. So anything that we can do that would improve the specificity of breast ultrasound would improve it as a screening tool. We also know that mechanical stiffness changes accompany the changes in tissue that are associated with pathology. And as a result, about 70% of breast cancers in younger women are detected with self-examination or palpation. So what is elastography? What is breast elastography? What do we mean by elasticity? And how might that image information help? Well, the typical introductory physics description of elasticity is done as a one-dimensional problem, and that is to hang a mass from a spring. We can calculate the force on the spring through Newton's second law, where we know the mass, we know the acceleration due to gravity, and so that we can calculate the force. If we hang a slightly different mass, for example, slightly larger mass from the spring, we stretch the spring a little further, we can calculate the difference in forces based on the difference in masses, we can measure the deflection of the spring from the two different masses, and then we can associate those two through what's called Hooke's law. Hooke's law relates the difference in forces to the differences in deflection and allows us to calculate a spring constant that characterizes the stiffness of the spring. If we want to extend that idea to 3 dimensions, it gets a little more complicated, but it's not too bad. The basic idea is that we want to first describe a 3-dimensional object. To do that, we start out with a 3-dimensional coordinate system. And we define these coordinate systems at our convenience. We align them however we want, we shape them however we want, but to keep things simple, we'll stick with the coordinate system that we're used to, up, down, left, right, front, back, because that's the one that we live in and we're familiar with it. So the next step is to consider an object in that coordinate system. And again, to keep things simple, we'll describe a simple box. Align the sides of the box with the coordinate system that we just defined, and now we have surfaces that are defined by our coordinate system. We're interested in forces, so let's consider a force on one of those surfaces. Now, the general case is not to have a force perpendicular to the surface. A more general case is for a force to come in at some odd angle. And with that, we use a second coordinate system to describe the orientation of the forces on the surfaces. So, we're using 2 coordinate systems, one to define the surfaces, another to define the forces. And if we shrink all this down into little tiny surfaces, then we can define stress, which is the average force per unit area acting on a volume element of the material. We also need to define displacements like we did with the spring. Again, we start out with a coordinate system that we're familiar with, and an object in that coordinate system, again a simple box aligned with the coordinate system. That volume element that we're interested in, or box, could be part of a larger volume, but to keep things simple, we'll just consider that isolated region. We're interested in displacement, so let's think about a point on one of those surfaces and ask, where does that point go when we deform the object? We can describe that with a displacement vector. So just like we did with forces, we use two coordinate systems, one to define surfaces, another to define displacements. But it's a little more complicated than that. We need to think about pairs of points and ask what happens to the pair of points as the object is deformed. To do that, we define, again, displacement vectors and consider the relative displacement of 2 points on a surface. And that is a measure of strain. Strain is the relative displacement of the material. So just to review, stress is the average force per unit area acting on a volume element in a material. And as an example, if you press on the skin surface with your fingertips, the pressure that you feel with your fingertips is the stress resulting from your tissue pushing back, and you feel the tissue pushing back with your fingertips. Palpation creates and senses stress, or a force per unit area. Strain is the relative displacement of the material. An engineer might describe it as the change in length per unit length, or how far did you press compared to how thick the tissue was. The elasticity imaging systems currently on the market display mechanical strain. We call them elasticity, but it's truly only the strain part of it. Just like we related forces and displacements in the one-dimensional study of mechanics, or springs, with a spring constant that describes stiffness, we can do an analogous equation in 3 dimensions that relates stress to strain through this more complicated set of constants that we call elasticity. So very similar forms in the equations for 1 dimension and 3 dimensions, stiffness and elasticity. We've been at elasticity imaging for a while. We created the first generation of the elasticity imaging systems that had everything integrated into an ultrasound scanner. It was based on the Siemens Allegra. The second generation system is based on the Siemens Antares. And later in the talk I'll be discussing some of the work that we are pursuing in developing the third generation system. These systems use generally linear arrays, particularly for breast imaging, but it's being extended beyond that to curved linear arrays, and I'll talk a little about that later also. For breast elasticity imaging, the technique is very much like the standard breast ultrasound technique. Freehand scanning with a slight amount of pressure applied with the transducer, or as an alternative, hold the transducer still, let the patient breathe, and let the chest motion induce the motion necessary for elasticity imaging. We've done this so far on over 500 subjects, and so I want to talk a little bit about what we've learned from those studies. Well, one of the things that we've learned is really a follow-up of the work that Brian Guerra described in his paper in 1997 in Radiology, and that is to compare the size of the lesion in B mode to the size in the elasticity, or E mode, image. We know that if the area of the lesion in the strain or elasticity image compared to B mode, the ratio of those, is less than or roughly equal to 1, that's usually suggestive of a benign lesion. We can understand that by the fact that benign lesions are usually restricted to the tissue that they're growing within. For example, a fibroadenoma growing in the duct is restricted to the confines of the duct. It doesn't infiltrate beyond the duct. So since there's no reaction or involvement outside the duct, the stiffness in the elasticity image is consistent with what we see in B mode. On the other hand, when the area ratio exceeds 1, that's more likely to be cancer. If we think about invasive ductal carcinoma, there is a typical associated desmoplastic reaction that surrounds the tumor, and that causes an area of stiffness that's larger than what we see in the B mode image as the hypoechoic tumor. Another consideration is the lesion shape. Typically, when the lesion size ratio is near 1 and we have a benign lesion, the shape in the B mode and elasticity image are very similar. In the case of the cancers, though, particularly when we have desmoplasia, the shape can be very different in the elasticity image compared to the B mode image. So how do we use that information? Well, here's an example of a fibroadenoma that shows many of the classic signs of a fibroadenoma, viewed here in the longitudinal axis here in the transverse axis. With color flow, we see that there is flow inside the lesion, so we're confident now that it's a solid lesion. Again, many criteria would suggest that this is a fibroadenoma. So what does elasticity image add? Well, one of the things this movie adds is to show how easy it is, or at least can be sometimes, to generate an elasticity image. You see that very shortly after the transducer is placed in contact with the skin surface, you get very high quality elasticity images. There is something to note that's a little easier to see if I show you a stationary image. And that is by comparing the B-mode image associated with the elasticity versus the normal B-mode for typical breast ultrasound, you see that there's very good contact with the transducer here. Typically you press hard enough to flatten tissue surfaces out. But an elasticity image is obtained typically with the transducer just barely in contact with the skin surface. The harder you press, the more the tissue flattens out, but you'll see in a few minutes that that can affect the tissue elasticity, and that might make it more difficult to obtain high-quality elasticity images. So keep in mind that the scanning conditions for normal B-mode imaging and high-quality elasticity imaging might not be the same. Another high risk lesion, or a lesion that based on mammography is seen to be highly likely to be cancer, BI-RADS5 based on mammography. And the question was, how might elasticity imaging help here? Well, that patient was sent to ultrasound for an ultrasound guided biopsy, and the obvious question that comes up is, where's the back of that lesion? How large is that lesion? Where can I safely biopsy? Well, we see from the elasticity image the confines or the extent of that lesion. We can see that we can't biopsy deep into the lesion. We have to stick to the upper area of the lesion as described by the elasticity image. So elasticity helps to define the lesion size much better than B-mode does, and can also be used in treatment planning. We see the same lesion in the perpendicular plane slid off the center of the lesion so that we don't see much evidence of the lesion in B-mode, but we see that in the elasticity image that we're still in a region of stiffness that is abnormal. So a reasonable question is, does this extend beyond just fibroadenomas and invasive ductal carcinomas? Well, a lot of the presentations that have been done in elasticity image focus on differentiation among solid lesions. One of the reasons is that we know that about 50% of all benign solid lesions are fibroadenomas, and about 85% of all cancers are invasive ductal carcinomas. So it's no surprise that they're the typical example. But do these same interpretation criteria apply to other lesions? Well, here's an example of an invasive lobular carcinoma where those same criteria do apply. We see that the size of the lesion in the elasticity image is quite a bit larger than it is in B-mode. And we also see that if we were to trace the boundary of that lesion in B-mode and then project that tracing into strain, we'd see a very different boundary than we see in the strain image. So the shapes are not the same, the size is not the same, indicative of cancer, same criteria. But solid lesions are only a part of the clinical problem. Benign versus malignant differentiation is important, but what about cysts? Can elasticity imaging help to differentiate cysts from solid lesions? Well, here's a small lesion that appears to be roughly 5 millimeters or so, embedded in what looks to be a normal background. But is it a cyst? Again, we measure its dimensions in perpendicular directions, 4 to 6 millimeters or so. In the opposite plane, about 6 millimeters, so it's a relatively small lesion. But is it a cyst? Turn on color flow where we see no evidence of flow, but doesn't really give you great confidence that it's a cyst. But when we turn on elasticity imaging, we see the characteristic bullseye pattern that's common among cysts. And we also see an apparent strain enhancement behind the lesion. So one of the things that we know is that when we see this bullseye pattern, that's very likely to be a cyst. We can understand that by considering how that bullseye pattern occurs. We know that if we have a fluid-filled cyst, then we have generally fairly low signal amplitudes, and as a result we have fairly low correlation from one frame to the next for the radio frequency echo signals that correspond to that data from the cyst. We also know that if it's fluid, the acoustic pressure can cause streaming, which tends to stir the fluid, so that we get, again, low correlation from one frame to the next, and that results in high apparent strain noise, and then if we use temporal smoothing or persistence, averaging a sequence of frames to generate one frame, that will result in an averaging of among those frames that have a fair amount of white in them that tends toward a high apparent strain or brighter than medium gray. On the other hand, around the perimeter of the cyst, but internal to the cyst, there isn't much motion, there isn't much decorrelation, and so the perimeter consistently looks dark. So we get a bright center surrounded by a dark ring on the interior of the cyst that generates a bullseye. I won't go into the details of that strain enhancement that's distal to the cyst, but our friends from Siemens explained that at a recent conference, and their explanation seems pretty robust. So we think that that problem is well resolved. To understand how well this information works, we did an observer study that involved 3 highly trained breast radiologists with a great deal of experience in breast ultrasound. And we asked them to do a variety of tasks looking at 100 different subjects, 50 that had cancers, 50 that had benign tumors. And so we had an enhanced patient pool, meaning more cancers than we normally would see in normal incidence, but that's to improve our statistics in the observer study. Again, we asked them to do several things, but the most important in terms of this study was to provide a confidence ranking of malignancy, view the B-mode image sequence, and provide some risk of malignancy. A rating of 0 would suggest that they believe there's no chance of malignant pathology. A rating of 100 would suggest that they believe they're completely confident that there is malignant pathology. And then they would look at that same data, but with B-mode and strain image information. And again, they did a number of things for us, but fundamentally, they reassessed their probability of malignancy after looking at the same data, but with B-mode and strain. The order of these was randomized among all the observers, so we did all the things that are necessary to perform a robust and reasonable observer study. But in the end, we applied receiver operator characteristic analysis, ROC analysis, on those confidence rankings to determine how well the radiologists performed at assessing risk. An ROC curve plots the true positive fraction versus false positive fraction, and the area under the ROC curve is a measure of performance. We plot here the data for B-mode data alone as the blue curves and B-mode plus strain as the red dashed curves. And the first thing that you see is that the red dashed curves in each case lie above that for the blue curve. Same is true when we combine the data to get an average observer performance. So the area under the curve is always increased when we have B-mode plus strain information over B-mode alone. When we combine that among the 3 observers, we get a statistically significant increase for the combined observer in their ability to assess risk based on B-mode plus strain information compared to B-mode alone. So from that study, we can say that elasticity imaging information adds new information that's not otherwise available, and that information helps radiologists to assess the risk of breast cancer. We also know from this study and our practice of a number of human subjects that the method for obtaining a high-quality elasticity image is not necessarily the same as it is to obtain a high-quality B-mode image. High-quality elasticity images are typically obtained with minimum surface pressure. Transducer just barely in contact with the skin surface, not pressing hard enough to flatten the tissue layers out. We also know from that work that elasticity image information can help us to better define the size and shape of a lesion, which should improve treatment planning. One of the other things that we learned from that study is that the contrast in a lesion can change as we deform it. The more we press on the lesion, the contrast may change. And we had some skeptics in that statement early on when we published that work in 2003. So one of the things that we've done that we're showing here is to use the displacement estimates that we use to form strain images to actually correct for the motion. So we apply those displacement estimates to correct for motion frame to frame, and if we've done a good job of tracking motion and correcting for motion, then the B-mode image shown below in motion compensated data should appear stationary, and it does. Similarly, the strain image also appears stationary, so you can watch a pixel in time and not be confused by the fact that things are moving like you are on the top, and see that the contrast in that lesion changes as we apply surface pressure. So, changing contrast, particularly large-scale changes in contrast, seem to be indicative of fibroadenomas. Invasive ductal carcinomas behave just the opposite, typically. As we press on them, they tend to get stiffer. It's rather difficult to see in these images because the change is more subtle and the background is more noisy, but we've measured it, it does get stiffer. So one of the things that we know also is that the contrast in an E-mode image can sometimes depend on how hard you press. In fact, you can press hard enough, particularly on fibroadenomas, to make the contrast completely go away. You can still see the lesion in B-mode, but you see a high-quality elasticity image with no contrast. And it doesn't mean that the technology has failed. It simply means that the method of applying the technology and the interpretation of the information may need to be adjusted. Again, typically high-quality strain images are obtained with minimal surface pressure, minimal pre-compression. Well, we can understand what's going on in that case by considering the stress-strain behavior among pressed tissues. This is data out of Paris Wellman's thesis, actually, not the Surgical Archive manuscript, but out of his thesis. And we use Paris Wellman's data because he obtained stress-strain curves with very minimal pre-compression and then over about a 10% strain range for a wide variety of breast tissue types. One of the things that we see here is that there are a number of ways of defining an elastic modulus. Elastic modulus is basically a description of the slope of the stress-strain curve. The tangent modulus is one that comes to mind. We just think of the tangent of the curve at some point, for example, at 8% strain here for an invasive ductal carcinoma. But there's another kind of modulus called a secant modulus, where it's referenced to some initial point like 0, and then from there out to 8% strain. So you see that the slope of the curve is very different depending on the kind of modulus that you define. But among these different tissue types, we have very different slopes of that stress-strain curve, so very different moduli. If we consider, for example, an invasive ductal carcinoma, very stiff tissue embedded in a fat background, if we deform that fatty breast 10%, the soft stuff, the fat, is going to deform a lot. The stiff stuff is not going to deform much. Well, we can actually image that quantitatively by doing a mathematical reconstruction to estimate a shear modulus, secant modulus distribution. And we're showing the same data that we showed previously, the B-mode image, strain image, and now a secant modulus that is scaled to the background. So these are not absolute moduli, but they're scaled relative to background tissue. And we see, as we suggested from strain images, that we get the highest secant modulus when we have the least amount of transducer pressure. And as we press on the fibroadenoma, the secant modulus decreases, red being very stiff, green being less stiff. On the other hand, the invasive ductal carcinoma, again, behaves just the opposite. The harder we squeeze on it, the more red or the stiffer it gets. So we can look at these movie loops of secant modulus and interpret that stress-strain relationship, how things are stiffening relative to each other. Another way of doing that is to do what's called a nonlinear modulus reconstruction, where we reconstruct a small strain shear modulus and then a nonlinear stiffening parameter, or a parameter that describes the curvature of that stress-strain curve. We see that the fibroadenoma starts out stiffer than the background tissue, but it doesn't really stiffen faster than the background tissue. On the other hand, the invasive ductal carcinoma has a stiff core area that is also quite nonlinear, stiffening much faster than the surroundings. So a nonlinear modulus reconstruction gives us a pair of summary images that tells us about the initial stiffness differences and the curvature of that stress-strain curve. Again, shown here, we're looking at the initial small strain modulus and then how much curvature there is in that stress-strain curve. Well, another thing that we're working on, in addition to quantitative elasticity imaging, is extension to 3 dimensions. There's a couple of methods of doing that that are on the market now. One is to use a mechanically rocked array, or a wobbler. Most of those are designed for obstetrics, and so they tend to be rather low frequency, particularly compared to breast imaging transducers. This is one way of acquiring 3D data. Another is to use a fully populated 2D array that electronically scans, no moving parts. This particular transducer type is called a capacitive micromachined ultrasound transducer, or a CMUT. Some folks, marketing folks for example, might call it silicon transducers or silicon technology. This is a prototype that Siemens has developed. It's a laboratory-based device that we have used to scan a phantom, and it's more designed for breast imaging, more appropriate for breast imaging. This is some of the data that we acquired from it. This is from a phantom that was designed to cause elevational motion or out-of-image plane motion as we deform it. But then for this data, we simply reconstructed strain, or created strain images based on just a 2D data sampling. So we created strain images that are very much like the strain images that we're presenting in breast tissue. And we see the characteristic noise in those strain images that's associated with out-of-plane motion. So we know that when we actually have 3D motion, but we're only sampling that in 2D, that elevation motion results in decorrelation, noisy strain images. On the other hand, if we do a full 3D tracking in that volume, then we see that we get very high quality strain images throughout the region of interest. Again, same data, but full 3D tracking, volume strain images. Using the curved linear array, we see that the tracking is not quite as good. It's a lower frequency transducer, so that's not surprising, but still, it's an adequate quality strain image, again, based on technology that's already on the market. So, to summarize the ongoing developments, we know that there are several available approaches to display elastic nonlinearity. One is to display movies of strain images with large deformation, and that's simple and intuitive. Another is to reconstruct a sequant modulus, and these are a quantitative image, although they're scaled to the background. And watching those through a movie loop and how tissue may or may not stiffen as it's deformed helps to interpret that stress-strain nonlinearity. But the most direct way to do it is to do a full nonlinear reconstruction, and that provides all of the information in just 2 images. And then, of course, extending all of this to 3D. So just to conclude, in the normal strain imaging that's available on the systems on the market today, one of the things you want to look for is consistent frame-to-frame information across the sequence of frames. When you see the same information through a series of, say, 3 to 5 frames or more, then you can have increased confidence that the information really is robust. In interpreting that information, you want to look at the size and shape of the lesion in B mode compared to the elasticity image. If the size and shape are similar, it's likely to be benign. If the size is smaller in the strain image than it is in B mode, again, likely to be benign. But if the size is larger in elasticity than it is in the B mode image, and if the shape is quite different, then it's more likely to be malignant. In addition to that, with the things that I just showed you, there's many developments on the horizon. There's many new applications beyond just breast imaging, so we think this is a very exciting future for elasticity imaging. I want to close by thanking the number of people that have contributed to this effort over the years. Notably missing from this list are my colleagues that did the 3D reconstructions with us. That's Paul Barboni at Boston University and Assad Oberai at Rensselaer Polytechnic Institute. Friends at Charing Cross Hospital in London, Mayo Clinic in Rochester, old friends from University of Kansas, and of course our good friends at Siemens. And with that, I'll thank you.